At the outset, I would like to thank the governing body of Indian Society of Organ Transplantation, Scientific Committee of Indian Society of Organ Transplantation for bestowing me with this prestigious oration. So thank you again. Thank you, organizing committee, for the excellent venue. So initially, I was a little wondering what to be the topic of this oration. Then we thought of probably in India there is no publications on 25 years long-term follow-up transplantations, and probably even in the world when we have searched, there is only one publication of 25 years outcome from the Ireland. So that's why we have taken this topic. We all understand Professor Vidya Acharya was actually known as the mother of the Indian nephrology. My big gratitude to her. She was first pioneer awardee from the South Asia by the International Society of Nephrology. This would be my agendas for today's presentation. So we all understand that evolution of kidney transplantation happened with the successful transplantation in 1954 by Joseph Murray and team on the twin brothers. When we talk about the India, it happens only possible after approximately 2 decades after that success in USA in 1971 at CMC Vellore by Mohan Rao, the surgeon, and K.V. Joni as a nephrologist. So this is then documented as a development. When we talk about the renal transplantation at SGPGIMS, the first transplantation was the deceased donor transplantation. And that happened on the 6th July 1989, because the institute was very young. It started in 1987. 1986 foundation was laid, and functioning started in 87. Then after 2 years, there was successful transplantation. This was by the joint venture of nephrology and urology. Over the 26 years, we have now 3,700 renal transplantation performed at SGPGIMS. Approximately living donor, most of the times, only deceased donor transplantation of 45. And we are also following more than 1,700 patients who has transplanted outside. And the giants of this transplantation program is sitting here today. Professor Bhandari, Professor Anand Kumar, Dr. Vijay Kher, R.K. Sharma sir, Amit Gupta and Anish Srivastav, they were the pioneer initially who have given drive to this transplantation program. So year-wise, we have never looked back, except there was some dip during the COVID time, never looked back in the transplantation programs. And we have, in 2013, we have started ABO incompatible transplantation, and we have now crossed 250 ABO incompatible transplantation at SGPGIMS. Where we are lacking is actually the deceased donor transplant program, but that was few every years, but not to that extent that happens in the southern part of India. This is our milestones of evolutions of the different programs at SGPGIMS, where we have started transplant immunogenetics program within the department that is of its own kind in India. So landmark of development at SGPGIMS was we have, as the drugs were coming to the India, we are very much aggressive in doing initiating that treatment, like the cyclosporine, MMF. We are the first to start with a laparoscopic donor nephrectomy. Professor Anand Kumar is here today. He was the man who started this donor nephrectomy. There were a lot of hesitations across India why to do this laparoscopic donor nephrectomy. We have started transplant immunogenetics lab, ABO incompatible transplantation, swab kidney transplantation. Then of late we have the robotic kidney transplantation as well. So we have balanced the academic records since the beginning. This was early days publications in kidney transplantation, clinical transplantation. What happened when cyclosporine was too costly? So we used to withdraw this cyclosporine after 1 year. So we have compared the early cyclosporine, late cyclosporine withdrawal versus those continuing on this low dose of the cyclosporine. What we have observed after withdrawal of the cyclosporine, acute rejection, late rejection, graft loss, chronic rejections was significantly higher. And the same data has been replicated from the PGI Chandigarh as well. Then after this tricontinental study, when we have seen this, there was significant decline in biopsy-proven acute rejection with mycophenolate mofetil of the 2 grams. Then SGPGI has also opted that. And we have opted mycophenolate mofetil in our programs, and rejections rate dramatically reduced from 40% to 13%. SGPGI program, usually we do inductions for low risk with and without basiliximab, and in high risk patients, antithymocyte globulins. In maintenance therapy, tacrolimus, mycophenolate mofetil, and prednisolone. Usually this is the program. You can imagine today's time, there is already a low dose antithymocyte globulins people are talking about. In 2003, this was the publications from our side. Whenever we were sending these publications, this used to come back. That why you are using this low dose ATG. So that was the recommendation. We are asking that a lot of infections with this high dose of the ATG. And ultimately, we have published in the transplant proceedings. So that's how we used to believe in our own eyesight, our own recommendations, our own thinking that why we should use this low dose of the antithymocyte globulins. We offered basiliximab to everyone, and there was some controversy whether in the low risk group of transplantation, whether this basiliximab induction is required or not. When we have conducted our study, we have seen biopsy-proven acute rejection even in low-risk groups was significantly lower than non-induction. But these are the patients of the sometimes, or some of the patients are from the cyclosporine era also. When we have followed this patient for the long term, we can see 10 years graft survival significantly low, significantly better with basiliximab inductions. Those who have not been given inductions has the lower survival. Whether this is death-censored or death non-censored graft survival, outcome was better with the basiliximab induction. We have then started looking at when we are using this basiliximab in so many patients, then we thought that hyperglycemia incidence went up. So this was my personal observation. Then we have one publication in basic science paper was there that probably the IL-2 receptor blockers is causing some beta cell dysfunction. And probably this might be the reason. So we have analyzed our data and we have seen when on multivariate analysis, hepatitis C infection and IL-2 receptor blockers had the higher risk of developing new onset diabetes after transplantation. And now we have the possible mechanisms. Potential modulation of the beta cell function with suppression of IL-2 signaling indirectly impairs pancreatic beta cell functions. And this was probably the reason of this new onset diabetes after transplantation in large number of the patients who are receiving this basiliximab induction. What does a patient expect to know from a physician? Why did the disease happen to me? Whether the drug will harm me? Why did you give me these medications? Will I recover? Is it possible to answer these questions precisely only on clinical grounds? Answer was clearly no. So in 2015, concept of the precision medicine came. Barack Obama has launched precision medicine initiatives based on after the success of the genomic and omics studies. And the concept was deliver the right treatment at the right time, every time to the right person. And NIH was at the forefront of the initiatives and developed to drive participant-engaged data-driven research combining biology, computation, medicine, genetics, and environmental knowledge. Here we can see tacrolimus we were using a lot, but we thought that we have multiple publications on steroid-assisted MDR1 gene study. So here we thought that we always talk about the P-glycoprotein involvement in drug levels, but this was never studied whether there is genetic any modulations which can help out in achieving these drug levels. So along with the cytochrome P450 enzyme, we have tried to study other genes like MDR1 genes also. And here we can see those patients who have the fast metabolizer who are requiring higher dosage of the tacrolimus to achieve the target level of 8 to 12. And those who were the slow metabolizer usually requiring little dose. And this has been shown that with the MDR1 gene, several times we have studied this MDR1 gene 2677TA, where we can see this homozygous mutant TTAA, whose population is approximately 18%. These group of the patient have higher expression of the P-glycoprotein, and that do not allow the drugs to enter into the system. And so probably this was one of the responsible factor for the low levels of the tacrolimus in such group of the patients. And when we have meld the both cytochrome P450 enzymes and MDR1 genes expressing this TTAA, what we can see, the slow metabolizer and this GG wild type of the cytochrome P450 was requiring 0.1 milligram per kilogram body weight of the drugs to initially achieve the target level of 8 to 12. Other way around, TTAA and 11, who are the fast metabolizer, was requiring higher doses, 0.15 milligram per kilogram body weight of the tacrolimus to achieve these target levels. So this is then it is also useful for in other scenario also. When we are looking after the many patients of the transplantation, azathioprine, many times we have observed azathioprine, as soon as you give the drugs, patient develops severe toxicity, bone marrow suppression. We are not in habit of getting this enzyme TPMT mutations. But if you are doing this, this will save many of the patients. But at our centers, our rheumatologists and clinical immunologists, they are doing this on the regular basis before giving this azathioprine for the routine purposes. Then voriconazole, some of this you can see type 2C9, 19, allopurinol. These are the drugs can have the interactions with this CNI, and we need to study these genetic markers, these genomics before instituting these medicines. Voriconazole, fungal infection is very common. We all understand sometimes the drug levels go high, but there are some fast or rapid metabolizers in which it is very difficult to achieve the drug levels. So many times we wonder why this patient is not responding. So we have some tools in the hand, there we can think of getting this done, why this patient is not achieving, why this patient is not responding to this drug. So genomics and pharmacogenomics is very important. Graft survival, nephrotoxicity, infection rate, new onset diabetes mellitus. By doing some of this genetic genomics, we would be able to understand why our patient is not doing that well. So then we thought that one of the student came to us and then told, I want to do PhD with you. So then we have taken this fellow. He is presently faculty in California. So we have tried to understood that once I was listening Dr. Remuji, he was talking about developing organ-wide. So he told for developing organ-wide, for the vessels formations, he gives BEGF. And then there was a lot. So I thought that why this is the one interesting BEGF, so we should study in our patient populations, in our transplantation programs. And we have seen some of the upstream mutations at 2578 and 2549 was associated with the development of this polymorphism, BEGF polymorphism in ESRD development. Then we have also studied the impact of the BEGF on acute allograft rejections. And we found that BEGF 1154 GG genotypes and downstream of 936 T allele was associated with vascular rejections. We have then again studied long-term follow-up outcome of this VEGF polymorphism associated with this any long-term outcome. Even after adjustment of all transplant-related covariates, association of the VEGF SNP, downstream of 2578CA and downstreams of the 2549, insertion and deletion with the graft failure was found to be very significant. Then I have got the one comment from one of the editor that you have put the kidney of donors and you have not studied the VEGF of the donor. So we have everything, got the funding from ICMR, and then we have studied that whether this donor's VEGF polymorphism had any impact on rejection or the kidney allograft survivals. And for the surprise, you can see donor VEGF has also an independent effect. Then definitely one thing was coming in mind that why our patients are failing, graft is failing, that chronic antibody-mediated rejections was one of the Achilles heel, what I feel. We have no definite treatment. And this PhD students, we have taken this PhD student directly under us as a DST Inspire Fellow. He came to us. And even in 2010, we have shown that T-bed positive, that is T cells infiltrations in the IFTA region, was associated with the poor graft outcomes. That was before this IFTA concept came, this was already in the literature. And then we have shown that patients, we have studied this peripheral circulation bloods, T cells, and in the intragraft T cells, this granzyme. What we have observed in the CABMR patient, even this granzyme levels in the circulation was low, but in the graft it was very high. So because of this sequestration of this granzyme secreting cells go into the graft and cause injury even in patients who have this ABMR. So it is quite possible, and we all understand most of the times we are not dealing with this antibody-mediated rejection alone, we are dealing with this mixed kind of the rejection. So that was another study point. Then we thought of why not to modulate this fibrosis in patient of the CABMR. Here we can see we have gone through the one of the paper by Masaki Murakami. And there they were talking about, this was one transplant done, tracheal transplantation. Here they were talking about IL-6 and IL-17 works in a loop, and they potentiate each other's activity. And fibroblast, what it is called, IL-6, IL-17 loop. And the fibroblast used to secrete some of these chemokines and behaves like immune cells. So why not to break these cycles of the IL-6 and IL-17 so that we can reduce the fibrosis induced by this IL-6 and IL-17, which is usually very common in patients of the antibody-mediated rejection. So we have planned this study. We have also studied in the control population. That was the nephrectomy populations, nephrectomy specimens taken from this. This was all, and we have very good cell culture lab in our department now. And there we are able to isolate the fibroblast from the kidney, and we can culture all. So we have isolated this fibroblast. Then culture supernant, we can see what IL-6 concentrations. When we are giving a stimulus with the IL-6, IL-17, it was doubling when you are giving both IL-6 and IL-17. So that we have studied for the CCL2 and CCL20. What is this CCL2? CCL2 is the chemoattractant for the monocyte macrophages and other immune cells. What is CCL20? It is the chemoattractant for TH17 cells. So once we are giving the both stimulus to these fibroblasts, they are secreting more cytokines. So what we have thought that why not to see the block effect of this. So when we have given anti-IL-6 and anti-IL-17, you can see mRNA expressions of this was going down and down. So this experiment was repeated 3 times in the lab. Then we have also studied in the peripheral circulation what is happening. You will wonder, CABMR patient has even higher level of IL-6, IL-17 as compared to patients with acute ABMR. So that was something giving us confidence, probably blocking both IL-6 and IL-17 and inhibiting this IL-6, IL-17 loop. It is possible that we might be able to reduce a little bit of the fibrosis. And we have proved this concept on Western blottings also. So in conclusion, anti-IL-6 and IL-17 may be the futuristic vision for treating CABMR and reducing fibrosis. But again, fear of heavy immunosuppression, infection, death with the functioning graft, that is always there in our scenario. And here we can see this is our 25 years follow-up data. Almost 445 patients death. Majority death happening because of the sepsis and bacterial infection, 33%. Fungal infection, 15%. Cardiovascular disease, only 15% of the patients. So, and malignancy 7%. Here we can see this, majority of the patients are dying because of the infection. And that is probably because of heavy immunosuppression. So that was the concern in our transplantation programs. So we have also studied, one of our PG has studied that 900 infection episodes, how that behaves on the long-term follow-up. What we can see, again, the genitourinary infection was significantly more. Here we can see 37% followed by pulmonary of the 25%, then GIT infections. And amongst this all types of infection, bacterial infection was 57%, 17% viral infection, and 10% of the fungal infections. And we expected this organism pattern is not different, Candida, Aspergillus, and Mucor in patients of the fungal infection, E. coli, Pseudomonas, and Klebsiella in bacterial infection, Cryptosporidium and Giardia in patients of GI infections. So, and when we have analyzed this graft loss and mortality with the impact of infection, fungal infection, 3.7 times hazard ratio of the graft loss and mortality is 3.5%. So majority of the patients who are dying because of these fungal infections. Then risk factor for the post-transplant infections when we have analyzed, ATG induction, prior to transplant tuberculosis and dialysis vintage were associated with this high risk of the post-transplant infection. And again, as compared to patient without infections, graft dysfunction, graft loss and mortality was very high. And we have followed this patient on the long term. When we look at those patients who develop this infection has patient survival approximately 10% lower. And when you look at the graft survival, it was approximately those who acquired infection at 20% lower. So how to prevent this infection and mortality? That was the major question. And COVID has shown us, we learned a lot of things from the COVID infections. And here we can see during the COVID time, those who have been given the very high dosage, dexamethasone equivalent to 7 milligram or more, these patients have more mortality, more readmission rate, more infectious and non-infectious complications. And one thing we have learned that many of the patients with the asymptomatic infection and lower grade of the infection can be treated with this domiciliary treatment. There is no need of hospitalization. We have also studied vaccination. Vaccination is already established, vaccination is already in the programs. And there we have studied this Covaxin and Covishield. And we have 3 papers in the vaccines, very important publications. We have shown some of the HLA polymorphism is associated with the seroconversion after this COVID infections. Humoral immune response of the SARS-CoV-2 infection and anti-SARS-CoV-2 vaccination in renal transplant recipients. There was no difference between the Covishield and Covaxins, but titer of this post-titers after the vaccination was significantly high than those who are getting only infections and some acceptable titers. Seroconversion rate in our scenario was significantly high. From the Western population, we have heard about the 56 or 60% of the seroconversion, but in our programs, we have documented records of all was 85%. So that was something which is different from the Western world. And then we have also seen those patients who have IL-6 and interferon gamma circulation is very high, that they have very high seroconversion rate. These are inflammatory cytokines. This was associated with this high. And these are few our publications on the dengue virus infection, chickenpox infection, and the cryptosporidium infections. And total number of kidney transplantation done, what I am going to present today of this Silver Jubilee story, was 2,800 patients. We understand ABO compatible transplantation, always debatable. ABO eye transplantation, something is going on the first floor in Hall B. Here we have two publications, important publication, multi-century. One of the publication has, after 5 years, there is not much of the difference, but before 5 years, you might have something like the higher mortality because of, in early phases, because of some infectious cause. That was the Jason study has shown. What we have observed, we have started our ABO incompatible transplantation in 2013, so it is not a long time, but 10-year survival is almost equal. And the 25-year survival of ABO compatible is 68.5%. When we look at the death-censored graft survival, here we can see it came down to 51% at 12 years, because this was the early phases, and this happens mainly because of 2 patients died because of the non-compliance of the issue in ABO incompatible group. Otherwise, if you look at the data, it is looking like very good, it is comparable to ABO compatible transplantation. One of the important papers which has been just accepted in Journal of Nephrology would be coming soon. We have shown why this patient of ABO incompatible who developed rejection is doing not that good. So what we have done propensity matching scoring of those who developed ABMR or rejections in ABO compatible and ABO incompatible, and then we have done this. What we have observed, patient who develops antibody-mediated rejection in ABO incompatible group has significantly lower survival, lower graft survival. It is 50% as compared to 79%. So that was something alarming, and that we came to know it is probably happening because of the presence of the anti-HLA antibody in some of the group of these patients. And this study again confirms that probably this is the strong HLA-DSA, which is the risk factors even on multivariate analysis in ABO incompatible, that is causing poor graft survival. This is our own data which has been published in Transplantation Direct, where again we have seen probably this was the pre-sensitization with the anti-HLA antibody that was causing the lower graft survival in patients who are sensitized. Then coming to pediatric patient survival in adult versus pediatrics, here we can see patient survival was lower in 67% in adult group as compared to 91% in the pediatrics age group, probably because of, but when we look at the graft survival rate, it was looking approximately similar. So higher patient survival, but similar graft survival in adult and pediatric transplantation group. We have seen overall patient survival at 25 years, it was 68%. So that was looking like the excellent data, and it is matching to the world's data. When we have seen the death-censored graft survival, 25 years, it was 57 years. When we have also seen this HLA was in-house, so all data was there. We have seen the HLA matching with this 0 match was estimated survival was 18, and when we go by the 6 match, it was 21. There are no much differences which we have observed in our scenario. Probably, most probably, we are dealing with most of these patients are living donor transplantation. So all death-censored graft survival, again we have seen with the 0 match, fully mismatch, it is only 16, but with the 6 match, it was approximately 21. So there was some impact on graft survival of this HLA mismatch, but not on that much on the patient survival. So patient survival, espousal versus non-espousal donor, 25 years, we have seen in espousal, it was 61%. In non-espousal donor, it was 71%. When we have seen the death-censored graft survival, espousal versus non-espousal, we can see 25 years survival in espousal was 56% and non-espousal was 56%. So again, death-censored graft survival is almost similar. Patient survival and donor genders, whether this male or female, 25 years survival, there is no too much of the difference. It is approximately 71% as compared to 66% in the females. Recipient's gender, when we look at the male as the recipient, the survival is relatively lower, 67%, 68%, and as compared to female, it was 84%. Patient survival gender directed in kidney donation, when we have male to male, male to female, female to male, and female to female, here we can see again there was no significant difference. Mean survival was ranging from 19 to 21 years. So this there was no independent impact. But 20 years survivors of the kidney transplantation, I am telling you, this was the only publication which we have found of the 25 years outcome from the Ireland study, from the Department of Nephrology from Dublin, where you can see the overall graft survival was coming about approximately 40%, 41%. So, and when we look at our data, it was also looking like extremely good represented outcome of this living donor transplantation in our programs. So take home message, kidney transplantation provides excellent long-term survival. Genomics and pharmacogenomics and its application in drug dosing precision reduces toxicity and improves outcomes. Death with the functioning graft, mainly due to infection, particularly the fungal infection, is major challenge. ABO incompatible transplantation in experience center may increase the donor pool. Swap and deceased donor transplantation is still evolving at SGPGIMS. We have some few photographs. This is the time to pay gratitude. So we have this intervention nephrology program at SGPGIMS. There are few fellows came from as an International Society of Nephrology fellows from the Myanmar, from the Bangalore, and this is photographs with our residents coming at my home on occasion of the Deepavali. So again, this is a very regular practice of making AV fistulas, looking at the intervention nephrology, doing kidney biopsy and teaching programs. And this is the renal and transplant immunology lab that has been developed at SGPGIMS. Everything is taken care by the Department of Nephrology. And we have all Luminex platform. We have in-house flow cytometric analysis, cell culture lab, everything we can have within the premises in our labs. I want to dedicate this oration to my parents whose attitude towards education made me eligible for this oration. I have two of my mentors. Usually both have Professor Amit Gupta and Professor R.K. Sharma taught me ABCD of nephrology. And thanks to all these colleagues for sharing H to Z of the nephrology. This is my bunch of colleagues at SGPGIMS and colleagues and different residents. These are collaborators with us. Brajesh Jadhav, he was the PhD student. Vinita Agarwal from pathology. Akhilesh Jaiswal, he has passed or finished PhD. Mohit also has finished PhD. Then Vikas Agrawal is my collaborator from the Department of Immunology. And these are the students whose attitudes towards the words day and night made me possible. There are many possible things happen because of their dedications, and they have to come even late in the night when you are doing some experiments in the lab. So thanks to millions of the patients who showed confidence and faith in me. And this is my family photographs. And I would like to thank Indian Society of Nephrology, Indian Society of Organ Transplantation. We have started giving orations in 2006, then Fuller Award oration in 2013, then Acharya Award oration in Kolkata, Ramdas Pisarodi oration this year. And My wife is a professor of gynae ops at KGMU. My son has just passed MBBS from FMC Pune. My daughter is has just passed +2 examination, being the All India rank holder 1. So that was the pride moment for us. And this is the Department of Nephrology where we have shifted from the old building to this new building. At the last but not the least, I will say I am the organizing secretary of ISNCon 2025 that is going to happen at SGPGIMS. So I would like to welcome you all. Get yourself registered. Anybody feeling any problems in getting registration or any accommodation, any problems, let me know. Thank you, ladies and gentlemen. Thank you for your kind attention.